Thank you for the invitation. I think I am a bit of an alien person here because I am a clinician, I am a neurologist, and so I am dealing with this disease, transthyretin amyloidosis, since many years now. And I would like just to present you the role, some role of aging in the expression of this fascinating disease. So you will maybe hear more about clinical work. So this disease, this kind of amyloidosis, is characterized by amyloid deposition, and the precursor protein in this case is transthyretin. And you can see here the two main targets of the amyloid deposition in this condition. The first target is the peripheral nerves, and you can see here on the cross nerve section, a nerve devastated with virtually no fiber left and full of amyloid substance. And the other important target is the heart, and on this cardiac biopsy you can also see that kind of prominent amyloid deposition. So in this condition, there is really a fibrillar deposition of transthyretin that you can see here on this electron microscopy nerve section. So what is this protein? It's a fairly small protein, 55 kilodalton, and it has a tetrameric structure with this dimeric structure here. In fact, its functional role is rather low in human, and it handles transport of thyroxine and retinol binding protein. In fact, there are two sites binding the thyroxine in the center part of the tetramer, and the retinol binding protein is bound on the lateral face of the tetramer. The main site of production of this protein is the liver, which produces 95% of the serum rate, and you will see the importance for the therapeutic aspect, and other accessory sources are choroid plexus and retina. So these figures show you what we think about the cascade, the pathogenic cascade of this type of amyloidosis. In fact, here is the tetramer of transthyretin, and there is a decrease of stability of this tetramer, mainly by two factors. Those two factors can be combined. One of them is an inherited mutation with an inherited variant of the protein, and the second factor is clearly aging. So there is a dissociation due to one or of this factor, or the combining of this factor into monomers, which in turn misfold into toxic species, and finally aggregates into fibrils of transthyretin that you have just seen. So the beginning of the story starts here in Póvoa de Varzim, just northern to Porto. And Corino Andrade, the famous neurologist, described the disease some time ago, 1952. And the disease is quite prevalent there, 1 per 1,000. It's a dominantly inherited disease, and the characteristic amyloid deposition of fibrils of TTR, and the main target is peripheral nerves, and so the disease is mainly expressed as a very severe peripheral neuropathy. Virtually all families are carrying the same variants, inherited variants, the V30M variants. And in fact, this disease in this site, in this area, occurs rather young in the life, in the 3rd to the 4th decade. It's certainly the most severe inherited neuropathy of adulthood, with a pejorative outcome within 10 years. You can see the large family history that we usually face, which makes the diagnosis rather straightforward. in fact, as I said, it's a very severe neuropathy which involves initially the small nerve fiber giving rise to thermoagic sensory loss at the very beginning, and you can have this kind of painless ulcer with also very severe autonomic dysfunction because autonomic nerves are small nerve fibers. And then large nerve fiber will be involved, giving a motor deficit. And we have generally loss of ambulation within 5 years, and the patient deceased within 10 to 15 years. So this is certainly the most severe inherited neuropathy of adulthood. You can see the involvement of the hand. It is a length-dependent neuropathy, so the feet are involved first, and then it's going proximally, and then the upper limbs are involved. Soon after the description in Portugal, there was other foci and area, or what we call endemic area, where the disease seems more frequent, and particularly in northern Sweden, where there are at least 300 families in those two areas, Piteå and Skellefteå. Sorry for the Swedish accent, I think there is some Swedish colleague here. In fact, all the families in this area are also carrying the same variant, although it's probably a different mutation, historical mutation. And there, the disease is starting much older, 56 years old. And then the Japanese families were described later on, with combined families. In Japan, we will see that there are many other mutations, but for the MET30 mutation, we have two foci here, quite like the Portuguese patient, starting very early in life, in the third decades. And then we have all across the country other families still with this V30M mutation, and with a very late age of onset, averaging 62 years old, and incredible male predominance of 10-for-1. Still presenting as this peripheral neuropathy. The Japanese, of course, studied more deeply these late onset cases, and in fact it turns that there is an important male predominance. Onset is quite delayed, as you can appreciate here, 64 years old in average. And although neuropathic symptoms are the initial symptoms in 80% of these patients, they do have mixed combined cardiac involvement, since the main cause of death is cardiac, heart failure, and sudden death in almost 2/3 of the patients. So this is the map that we have now of this disease that is really present across the world. You can see the area of what we call the endemic area, where the disease is most prevalent. But really the disease is present in all parts of the world, the United States, where the V30M variant is the less frequent, in the South America, also in Japan, in China we have now some reports, Australia, New Zealand. In Europe, we have many, the disease described in Western countries, France, Italy, Germany, with many different ATTR variants. And certainly the disease is still underdiagnosed in Central Europe, Eastern Europe, and in Africa. Just a quick word on the TTR gene, which is quite useful nowadays, and which has become a major diagnostic tool for helping for the diagnosis. It's a very small gene, including 4 exons and 200 base pair each, so very easy to sequence, and as I said, a very important diagnostic tool for this disease. And we have now a heterogeneity of the mutation, more than 120 missense point mutation described. Many of them are pathogenic, and we see that the phenotype of the disease is changing a little bit, although many of the mutations are associated mainly with a neuropathy, like the V30M we have just seen. Other mutations do express as a proeminent cardiomyopathy or an isolated cardiomyopathy, particularly this isoleucine 122, which was described in the Black American population in 1997, and it seems that to be rather frequent in this population, as in the first series, Jacobson found as many as 4% of heterozygous in a large population suburb of African American. Thanks to a large database, TAOS, which is held since 2008, we have now important collection of clinical data on these patients. Since this database includes more than 2,000 patients, so it's really important for clinical to increase knowledge on clinical expression and treatment of this disease, treatment effect. And what we can see is that clearly the patient with non-V30M mutation do have much more cardiac involvement, and they present with cardiac feature much frequently, 11 times as likely to experience cardiac symptoms first compared to the V30M patient. Those patients are also much older. And here is also data extracted from TAOS, where you can see that we selected the mutation having cardiac expression, virtually isolated cardiac expression. And what you can see is that the onset of the disease is much older from the 4th to the 8th decade. So clearly, when there is a cardiac expression of this disease, this inherited disease, is associated with aging and with an age process. Please note here that we have this curve of patients that we will see in a minute, which is the senile systemic patients. Just another quick word on this series of isoleucine patients with the cardiac expression. Buxbaum relatively recently examined a very large sample of carriers of this mutation, and from two large cohort of African American population. The age was from, you can see here, middle age to old age. And what he could extract from this study was that before 65 years old, there was absolutely no impact of the allele, pathogenic allele, on cardiac function and mortality. Whereas the impact appears after the age of 65 years old, with a higher risk of heart failure, 2.6, and a survival significantly lower. So I think it's really convincing data for this particular mutation and for cardiac mutation in general to document their late onset expression with a pure cardiac expression. So probably a combined role of aging. So I like very much this slide brought by Claudio Rapezzi. I think it's a very good summary of the spectrum of the inherited transthyretin amyloidosis that we can see nowadays. Going from the neuropathic, the pure neuropathic spectrum, generally associated with the V30M mutation, to a mixed cardiac and neuropathic presentation associated with many other mutations, and to the pure cardiac presentation associated with this mutation. And I think you could add here the aging process, and really we see these mutation, mainly in young onset patients, and then we see cardiac mutation in later onset patients. So I think there is really an age effect in the phenotypic presentation of this disease. In addition to that, we have this other aspect of the disease, which is senile systemic amyloidosis. In fact, it is associated with amyloid deposition made of wild-type transthyretin, and this condition, as you may know, was described in post-mortem study. Its prevalence in post-mortem study ranged from 12 to 25% in patients really old, so in elderly, over 80 years old age. You can see in the autopsy of one of our patients, the main target of the amyloid deposition in this case is the heart, and you can see here macroscopically on the heart of our patients the amyloid deposition, the huge amyloid deposition. So there is an excess of male predominance in this condition, and obviously we don't know really yet the prevalence of this condition in the elderly population. But we have now much better tool, we'll see in a minute. So the main expression is cardiac with hypertrophic restrictive cardiomyopathy and conduction disturbance, atrial fibrillation responsible for syncope, systemic embolization. So mainly in the elderly after the age of 80 years old with male presentation usually. But this is a systemic disease, and we have accumulation of amyloidosis in other tissue, namely ligaments and tendons. And recently, the Japanese demonstrate that in 1/3 of carpal tunnel syndrome having had surgery, they could demonstrate that there is senile systemic amyloidosis, and it was a general cohort, so probably this disease is much more frequent than is usually seen. The accumulation can interest other tissue like lung, bladder. We have now, thanks to the cardiac imaging, a very potent tool to perform the diagnosis of this cardiac form, and namely with the echocardiography. You can see here this typical aspect of hypertrophic cardiomyopathy with a huge increase of septum, ventricular septum and ventricular wall, and a restrictive pattern since the ejection fraction is relatively preserved. MRI can also contribute to the diagnosis with this pattern of hypertrophic cardiomyopathy and this relatively specific pattern of late gadolinium enhancement indicating amyloidosis. So these are now potent tools to perform the diagnosis of senile systemic amyloidosis or cardiac form of TTR amyloidosis. Another important tool is scintigraphy. We now currently use this 99 technetium DPD scintigraphy, which is a derived phosphonate scintigraphy, which uptake into ATTR cardiac amyloidosis is relatively specific. It's not fully specific, but when you have this type of imaging with this DPD scintigraphy, this man is highly suspected to get TTR amyloidosis, wild-type TTR amyloidosis. Obviously, you need the confirmation by tissue biopsy, heart biopsy, or ligament carpal tunnel biopsy, as we have just seen, with documenting the staining for TTR with a negative sequencing, gene sequencing in this case. So we have now potent tools to diagnose these patients, and it's likely that this disease and the rate of this disease will increase in the next future. Just a very few words on some therapeutic approaches that are going on in these conditions. To date, we know only this approach, so trying to prevent amyloid deposition in order to stabilize the disease progression. So one of our main goals is to perform early diagnosis. It's a major goal in the next years for all these patients, thanks to the genetic counseling in families, for instance, and thanks to the improvement of the cardiac imaging and the diagnosis in senile systemic amyloidosis. And the first cellular therapy that was used was liver transplantation in familial amyloid polyneuropathy. This was performed by the Swedish team in the 90 years. And we now, with 20 years of, more than 20 years of experience, know that this first cellular therapy is able to stabilize the neuropathic process in the young onset V30M patients. Whereas it's not able to stabilize the cardiac progression of the disease, probably because there is some combined feature linked to aging. We have now some other promising therapeutic approach I just summarized for you. We have this first therapeutic approach, the tetramer stabilizer. We have two molecules currently available. Tafamidis was developed and has been marketed by Pfizer in 2011. It has been shown that this drug is well tolerated and able to slow down the neuropathic process, mainly in the Portuguese population. Diflunisal, which is an old anti-inflammatory drug, has been shown also having slowed the neuropathic process in largest population. Those tetramers are now available, and it's relatively important to start these drugs as early as possible. And then we have now this promising approach of decreased the gene translation through gene therapy. We have now two trials, one with antisense oligonucleotide and the other with silencing RNA for TTR. And it's two phase 3 trials, and I think it will be really important to get the clinical result within the next 3 years for this trial. Other promising approaches are in development. So I think relative to aging, yeah, it's just finished. We have just seen that the different spectrum of the disease with aging, neuropathic phenotype in the early onset V30M TTR, mixed neuropathic and cardiac phenotype in the older patients, systemic senile and non-mutated patients. I think it's well, it's really relatively certainly we don't know what are the underlying process of these phenotypic differences. There are some differences in the amyloid fibrils related to aging, and certainly there are a huge amount of work in order to elucidate those factors and the tissue specificity. Just want to thank all the team involved in Henri Mondor in the care of these patients, cardiologists, neurophysiologists, neurologists, hematologists as well. Thank you very much.
Thank you. So, well, sorry, we have 25 minutes over time.
It'll be a quick question.
Okay, one question, that's all.
So I want to ask about the genetic stabilizing variants of transthyretin. I'm sure you know about them. And you probably know that there was a study last year from the Danish group showing a really big change in longevity, not in trans-heterozygotes, but actually in the general population, in heterozygotes for these versus non-carriers. Now that we are getting close to being able to do gene targeting in vivo with CRISPR and so on, what do you think about that as a way to actually prevent cardiovascular disease?
I think it's a very important question, obviously. All the work that has been done, as probably you know, with the stabilizer was performed only on neuropathic course, and we have absolutely, virtually, we have very few data on the stabilizer on the cardiac aspect of the disease. So the trials are now starting, and I think it would be obviously very important, and your obviously trial you mentioned is very important in order to try to slow down the process. I think the major clue in this disease now with those tools is, as I said, the early diagnosis. Because when you come too late, all the tissues are invaded by amyloidosis. It's obviously too late for the functional aspect of the organ.